We know that there is a lot of research which is going on continuously in the field of pediatric endocrinology across the globe, and a huge number of publications which are there, which happens. But unfortunately, most of those publications do not result in changes in terms of our clinical practice. The reason for that is that we cannot go and look at each and every paper individually. So guidelines are in a way a bridge so that we can look at the current evidence available, and which will tell you whether you need to change your practice or not. And this is what the theme would be. So why do we review guidelines? Is that because this provides us information which is evidence-based. Now, most guidelines are by the leading experts which are there from the group. So today we're going to talk about guidelines which are coming from the International Society of Pediatric Adolescent and Diabetes, the multiple pediatric endocrine societies which postulate the SGA guidelines, as well as the endocrine society. So they are usually evidence-based, and they provide us some perspective as to what is relevant from a clinical perspective, and a huge amount of data is filtered from that regards. We know about what's happening in that particular field, and often it is very difficult to understand, interpret. So this is like something which is made easy for us to not go towards all that literature review, and we go from that perspective. So what basically we are going to do is to basically try to cover the various aspects which are relevant in terms of guidelines and that perspective. All of you can go and have a look at our website, learning.growsociety.in, which provides a lot of information about various aspects of pediatric endocrinology. We've got various courses available which provide insights and other tools for pediatric endocrinology. There are a lot of other activities like journal club, like grand rounds, as well as the lecture series which is there. There are publications as well as the mobile application which can be used from that regards. So today I'll be focusing about 3 specific topics. The first topic which will be taken by me would be on type 2 diabetes guidelines. Then we have Dr. Dhwani, who will be talking about the SGA guidelines by the International Pediatric Endocrine Society Consortium. And then Dr. Dhwani will talk about the gender discordance guidelines via the Endocrine Society, and how do we assess from an endocrine perspective largely from that regards. So as I said, we will try to focus about all this. What is the evidence, what is the state of art, and how we can implement it. So what we have done is that we have used cases to pose specific clinical query where there is a lacunae in terms of current practice, and see what these guidelines change, whether we need to change our management, our assessment, and other aspects on that regards. So when we look at a guideline, we have to particularly look at how much literature they have really reviewed. So that becomes important. Whether they have used a standardized protocol, which is the grading protocol for evidence, which I'll touch base about a bit in the next slide. What weightage is given to individual aspects, and whether there is any particular bias or not. So what guidelines we are talking today are based upon the well-known international bodies which have published so many guidelines. So many of them do not have all these issues. But whenever you are assessing, look at how much literature was reviewed, who were the people involved, whether they were showing any bias in that regards or not. And that's why this grading of evidence becomes extremely important. Now, remember that guidelines are not the all end all as far as clinical practice is concerned. Now, generally, guidelines tend to dictate that this should be done. Now, you should remember that this should be done in an ideal situation. Now, every child is different. Every scenario is different. There are socio-economic, racial, ethnic, so many issues. So we cannot just follow everything which is there on the guideline. We have to adapt them. Second, they do not talk about individualized care. So we have to individualize the management. As I said, more often they are community-based, and often feasibility issues are there. You have some complicated investigation or some very expensive treatment which is available, which you cannot utilize in your patients. So you don't have to really think that, okay, we are doing something wrong. So you have to basically go through the guideline and try to see what you can do within your resources.
So before this, the SGA guidelines for growth hormone was last seen and published in 2006, and this is the update to that study. Why do we need this study? We know that SGA is birth weight or birth length less than -2 standard deviation for gestational age, and we need to know whether or not a child is SGA because it has implications at each stage of life. Not only in the neonatal period where it has a higher risk of hypoglycemia and hypothermia, but in the childhood and adolescent period where SGA children born SGA have a higher risk of persistent short stature, and those with a rapid catch-up may have insulin resistance, increased fat mass, a lower lean body mass, and lower bone mineral density, which ultimately leads to a higher risk of cardiometabolic complications in the adulthood period. There have been no clear universal guidelines about how to monitor these children, what protocol to use, what other diagnostic tests to do, and about the growth hormone therapy in these children. Let us have a look at these guidelines through examples. So we have a 2-year-old boy with poor growth. On history, there was no history of systemic illness and no history of pica and was developmentally normal. On inquiring further, we found that he was born at 32 weeks with 1.6 kgs, had a NICU stay mainly to establish feeding, but otherwise had no hypoglycemia or hypothermia, no complications during the neonatal period. This child at 2 years had no syndromic features on examination and had no features of micronutrient deficiency. His weight was at minus 1.5 standard deviations and height at minus 2.3 standard deviation. The attending physician went ahead with screening investigations, which were normal, and decided to start the child on growth hormone therapy. Now, what we need to understand here is that 1.6 kgs at 32 weeks was actually an AGA child. So, the guidelines recommend an accurate classification of SGA, preferably to use national growth chart so that bias is avoided. And this child on follow-up had normal catch-up without growth hormone therapy. Looking at another example, so we have this 2-month-old.
That's a very important lesson, that we should not assume that somebody is SGA. Always look at our own chart. So which charts would you recommend?
Intergrowth 21 charts are used to monitor the fetal growth.
They would be definitely recommended.
Yes. So we had this 2-month-old child who was brought in for a routine vaccination visit. We found that there was a history of antenatal maternal anemia and preeclampsia, and the child was born at term with weight of 1.7 kgs. Now, at 2 months of age, the child had a weight of 3.6 kg at minus 3.3 standard deviation and a length of 52 centimeters at minus 3.2 standard deviation. The head circumference was also on the lower side at minus 2.3 standard deviation score. So now that we've identified that this child was on the lower side, this child was definitely an SGA, what do we do? How do we go about? So the guidelines recommend that the first step, of course, here is that you prevent from developing an SGA. So in the antenatal period, the mother should have received good antenatal care, frequent monitoring and ultrasound examination to pick up abnormalities and received proper care. After that, every child who was born in SGA should be carefully followed in the first year of life by a neonatologist or pediatrician to evaluate growth, weight gain, and neurodevelopment. And these trajectories should be followed to identify malnutrition, growth faltering, or early excessive weight gain catch-up. So that's how we went ahead. In the next visit, at 3-month visit, we found that his weight was at 4.9 and length at 57.6. So from the previous SG scores, he is definitely in the plus 0.2, 0.3 gain we could see. But the attending physician saw that the child was still at -3, so he advised formula feeds for this child. So the guidelines mention that the best for these children to not have an excessive weight gain is that they continue breastfeeding for 6 months of age. It is recommended to avoid additional nutrition supplements in these children, except when you see obvious clinical features of malnutrition.
Why do you think breastfeeding is important in terms of this first 6 months?
So breastfeeding will allow a normal weight gain and will prevent excessive weight catch up in these children.
And it is very clearly shown that exclusive breastfeeding in the first 6 months of life is a known protective factor for subsequent obesity,
yes,
type 2 diabetes, PCOS, so everywhere
yes,
it has been shown. These children who are already, there are two groups of children, one who may develop too much and they will develop complications, and one who will develop too little. So there definitely breastfeeding is something which is very important to follow.
And moving on, so looking at the recommendations for follow-up, weight, length, head circumference, and weight for length should be monitored every 3 monthly in the first year of life. every 6 monthly in the second year of life, and annually thereafter.
This is pretty much for
Yes,
every child.
every child,
So this
yes.
is not even for SGA, but definitely more for them.
Yeah. So this is how we went ahead with this little boy. On follow-up, we found that by the age of 1 year, his weight centiles were definitely crossing lines, whereas his height centile remained parallel to the third centile line. So it is important that in children born SGA, an excessive postnatal weight gain should be avoided, since it is associated with a less favorable cardiometabolic risk in the long run. And what is more important, although not something we would look for in a 1-year-old child, but just crossing of weight centiles should not be the reason where we go ahead with glucose profile and lipid profile in these children. So assessment of fasting glucose and lipid concentration is recommended in SGA children only when they are overweight or obese or have clinical features of metabolic disease with positive family history.
What would be the first sign that your child is actually going towards the obesity? One, of course, is this. If you look at the BMI, there is any way which can tell you. So normally we see that the BMI comes down and then it goes up.
Yes.
So this is known as obesity rebound. So if the obesity rebound is happening earlier, it is an indicator that this child is going to develop a lot of metabolic complications. Okay. So that obesity rebound also is very, very important. Carry on.
And as per the recommendation, we kept following this child. So we found that at 2 years of age, his weight had pretty much stabilized, but his height remained parallel to the third centile curve. So catch-up growth is defined as any growth more than 0 standard deviation or more than median for chronological age and sex. When a child born SGA has persistent short stature, that is less than minus 2.5 standard deviation by 2 years of age, or less than minus 2 by 3 to 4 years of age, without signs of catch-up in the last 6 months. That is the point where you should refer these children to a pediatric endocrinologist.
This is an important guideline. Before that, we used to say 2 to 4 years. So it was based upon the growth hormone starting indications.
Yes.
So like there are different indications in US and Japan, which we'll talk later. But this very clearly says that the quantum of growth failure is also important. So if you are much more compromised at a younger age, don't need to wait from that perspective. Frankly speaking, most children, 90% will catch up by around 18 months. So 2 years itself is a bit late, but this is fine. If you're just between 2 and minus 2 to minus 2.5, you can take it. But otherwise, this becomes a.
Yes, so as sir has mentioned, the American guidelines have a cutoff of 2 years of age, wherein they also start in growth hormone therapy. But in the low to middle income countries, because there are so many other confounding factors responsible for a poor catch-up, it has been advised to wait for a period of 3 to 4 years. And by 4 years of age, by the time the child presented to a pediatric endocrinologist, his height was 92 centimeters, which was minus 2.7 Z scores, minus 2.7 standard deviation, and weight was at 15 kgs. He had no obvious dysmorphism, and general systemic examination was normal. The screening investigation was normal. So what do we do? Where do we go from now? Let us look at the recommendation. So an SGA with short stature. So height at minus 2.7, he's definitely short stature. One must ensure that they use age, sex, and population specific growth charts. Using WHO growth charts for an Indian population may falsely classify our children as short stature, and therefore it is important to use ethnicity.
But at 4 years, you'll be using WHO.
So, I mean, sorry. Yes, you will be using.
Yeah. But in subsequent you should look at local regional charts.
Another important thing that this recommendation guideline recommends is that any child born very preterm, less than 28 weeks, or severely SGA, one must always keep a high index of suspicion for syndromic short stature in these children and actively look for dysmorphism, look for skeletal dysplasia or a disproportionate short stature as simple markers at microcephaly, intellectual disability. So these are the subtle things that one has to be looking for when you look at very preterm or severely SGA children.
I think this is important that you have to think of syndromic causes. There are two reasons. One, the responsiveness may be different. Yeah. And second, which we'll discuss subsequently, whether there are contraindications to growth hormone therapy, which also may become relevant.
Yes. So in our index child, we've seen that examination was normal, initial screening tests were normal. So what endocrinological workup is needed? So we need thyroid profile and IGF-1 levels at outset, and IGF-BP3 levels only if IGF-1 levels are low. Growth hormone stimulation test is only indicated in those suspected to have a growth hormone deficiency. And while this holds true clinically, the Japanese guidelines recommend a growth hormone stimulation test in all these children, because if found to have low growth hormone levels, then one can start growth hormone at a lower dose as compared to those for
I
estrogen.
think this is a very important issue. Now, if you are not doing growth hormone stimulation test, why are you doing a IGF-1 also is a questionable thing. So IGF-1 is just a screening test.
Yes.
So they ultimately say if IGF-1 is low, then you do IGF-BP, then what does it make a difference? So generally, if at all, one really, if you talk about the cost effectiveness of evaluation, if you want to do a growth hormone stimulation, you go for a stimulation. Because stimulated growth hormone is an important indicator of responsiveness to growth hormone. And that's what Japanese studies do. Otherwise, IGF-1 itself is also not, is superfluous. It's not going to make a difference unless you think this is GHD. How will it help otherwise?
Will basal IGF level help us in subsequent monitoring?
So how will it help? Because your aim is not the delta IGF-1. You're looking at how much is the absolute IGF-1.
Okay.
So you want the absolute IGF-1 levels to be in the normal range, not that the increase is this much. So that's why I said guideline does not mean that you have to follow everything. You have to think of what is best for your own scenarios. Yeah, please carry on.
And another thing that the guidelines, which was previously not mentioned in the guidelines, was what genetic workup and who do we go ahead for genetic workup. So if you have a child, so in any short stature, we know that we look at the upper segment, lower segment ratio, we're looking at microcephaly, we're looking for dysmorphic features. So if you have a child with body disproportion or skeletal deformities that you can identify, then you go for a skeletal survey. Refer to a geneticist if applicable in your clinical scenario, and subsequent genetic tests may be required for confirmation of diagnosis. If you have abnormalities in the GH IGF-1 axis and or IGF-BP3 levels, then you need to go for specific genetic tests to make a diagnosis in this scenario.
Yes, if you are looking at a severe IGF-1 deletion, IGF-1 resistance, which is exceedingly rare, there definitely the role is there, but not for everybody.
Yes.
I think that would be good.
If you have dysmorphic features, microcephaly, developmental delay, intellectual disability, and or major malformations, you're looking at a syndromic short stature. The subsequent tests will depend on the phenotypic characterization of this child, and one may consider referring to a geneticist. If it is a known genetic syndrome, then you go for a specific test. If it is an unknown genetic syndrome, then you go for whole exome sequencing, whole genome sequencing, whatever is clinically
Now, the big question which is there is, do we need to do genetic testing in everybody to exclude the contraindications to GH therapy? That's a big question. What do they say on that? So they have mentioned in everybody. Because there is a debate whether everybody should have an NGS before not easily available. You don't want to give treatment in those who are not really not candidates for GH therapy. So if you are thinking of GH therapy, this is something which may come up, whether you want to do it or not.
In the last subcategory where you have no other features suggestive of a syndromic short stature, you're looking at idiopathic or isolated short stature. So here karyotype is advised for girls, and one may consider growth disorder panel or whole exome sequencing.
So ultimately in everywhere they're talking about genetics.
Yes.
Whether you have features, they don't have features. So it is not going to make up. So this algorithm, although it is an algorithm, it really ultimately leads to the same thing.
Yeah, use your clinical.
And then you have to look at genetics everywhere, genetics are coming up on that. But definitely we should not go for genetics like for diagnosing GHP. Like we have seen patients in the genetics of figure, but this is the way things are going forward. Carry on.
So in this index child, based on the recommendation, we went ahead with thyroid profile and IGF-1 levels, which were in the normal range. So looking at growth hormone therapy. So you have a short child, you're thinking of growth hormone therapy, but does it really help in the long run? So we have seen that the growth hormone therapy helped with normalization of adult height. It helped decrease the fat mass, improve lean body mass. However, it does increase insulin resistance to some extent. but there was improvement with the blood pressure profile and improvement in the bone mineral density and psychosocial functioning. So how much or who is a candidate? It is indicated for persistent short stature at any age after which catch-up growth is unlikely, which, as sir has mentioned, usually it happens by 18 months of age. So 2 years also may be late, but in low to middle income countries, it is recommended after exclusion of all other criteria of all other confounding factors by 3 to 4 years of age. So we've already seen when to start it and when not to. So growth hormone therapy is not recommended in several genetic disorders that have a predisposition to develop cancer, especially chromosomal breakage syndromes and DNA repair disorders. And as I've already mentioned, growth hormone stimulation therapy is not recommended before starting growth hormone in all these children. How much to start it with? So the growth hormone dose recommended is 33 to 67 mics per kg per day. It is preferred to start with at a lower dose and then subsequently increase based on the clinical response in children. A higher starting dose within this range may be considered in those with marked growth retardation.
And those who are diagnosed presenting late.
And those
most of our patients may actually be coming at 8 years, 9 years, near puberty. So that is the time you have to give a higher dose, maybe preferable. So 67 microgram per kg per day is a big dose.
Yes.
It is very, very big dose. So generally we will start by around 0.33 is good, maybe up to 40, but that's the upper limit.
Yes. And they've also mentioned that starting upfront at 67 is not recommended. So IGF-1 levels are subsequently monitored to look for adherence and for safety profile. And growth hormone dosing based on IGF-1 titration alone is not recommended. One has to look at the clinical benefit that it offers.
So basically, if you titrate, there is one study which was looked into the GHD group. If you titrate based upon the IGF-1 level, your dose becomes 3 times. So if you're giving 30, it becomes 100 to get the IGF-1 high. Now, everybody with the same IGF will have a different response because the receptors are also different. So it is of no sense to use IGF-1 for titration.
Right. And while on growth hormone therapy, one needs to monitor weight and height at each visit every 3 to 4 monthly during growth hormone therapy. Sitting height is necessary for initial because there may be syndromic forms of short stature who may or may not benefit or who from growth hormone therapy. So it is at the start of therapy, one needs to look at the sitting height, blood pressure. That is again recommended at each visit, Tanner staging at each visit. IGF-1 levels is something I wanted to point out is it is advised at start of therapy and then annually thereafter. Thyroid profile is recommended at start of therapy and annually thereafter. Lipid profile is not recommended unless clinically one sees an overweight or obese child, but subsequently at cessation of growth hormone therapy, one needs to get the fasting lipid profile. Fasting glucose, insulin, HbA1c again at the start of growth hormone therapy and subsequently if clinically indicated. Another thing that I wanted to highlight here is bone age. We know that SGA children have a higher risk of precocious puberty by about 5 to 10 months before the AGA children and have a rapid progression of puberty. So bone age, although not routinely recommended, especially not in the pre-puberty children, but by 8 years of age, it is recommended that one get an annual X-ray.
The reason that they have to put bone age a bit down is that the reliability of bone age in SGA is less because many of them have skeletal abnormality. So you cannot really reliably judge the bone age. But yes, of course, because most of our patients are late, we have to monitor them very close during puberty.
So our 12-year-old boy was started on growth hormone therapy and had shown improvement in the height, but we noticed that even by 12 years of age, his height was at 134 centimeters at minus 1.9 standard deviation, whereas his mid-parental expectation was at a higher percentile. His pubertal staging was already PhD with testicular volume of 4 cc, and a bone age was closely followed by at 11.8 years. So in this child, even after increasing growth hormone dose, we saw that the His clinical response was suboptimal, and especially now knowing that he may enter puberty and may have even less time, what do we do in this stage? Looking at the guidelines. So, who is eligible for GnRH therapy? A growth hormone treated child born SGA who at the onset of puberty comes with an expected short adult height, or SGA children who were SGA who present much later, like sir has mentioned, who come later in puberty and have a less time for achieving growth hormone adult growth. GnRH therapy is recommended for a period of 2 years, and it is shown to increase height by plus 6.6 centimeters in boys as well as girls. Over the period, safety has been established for GnRH therapy along with GH therapy. However, significantly long-term studies are still needed.
So this is a new recommendation that
Yeah.
if you are short at onset of puberty, think of GnRH. Now this we were doing, but now it has come up in the guidelines.
So this child was started on GnRH therapy. Puberty was delayed, postponed for 2 years, and this had shown a significant improvement in the final adult height in this index child. Looking at when to stop growth hormone therapy. First is no response. When you see poor adherence or repeated non-adherence, that is the period where you should not go ahead with this, because French studies have shown that in SGA children who were started on growth hormone therapy for a period of 3 years, and then when the therapy was stopped, they had shown a catch down growth. So in poor adherence or repeated non-adherence, one may not go ahead with growth hormone therapy, and when no clinical benefit is seen in a child. The other point where you stop growth hormone therapy is when adult height is reached. That is when the rate of growth is less than 1 centimeter in 6 months, and with clinical evidence of closure of epiphysis. In this SGA child started on growth hormone therapy, in the adult run with growth hormone therapy, there was what you've seen as a normalization of adult height, a decrease in fat percentage, increase in lean body mass, improvement in bone mineral density. Insulin sensitivity improves after stopping growth hormone therapy in the long run. And as far as the studies have shown, followed up for 5 to 12 years, growth hormone therapy has been shown to be safe in the long run in improving the cardiometabolic profile in these adults. So upon discontinuation of growth hormone therapy, adults born SGA should be counseled to adopt a healthy lifestyle, because we know they are at a higher risk of cardiometabolic complications, and long-term follow-up of previously SGA adult is recommended to identify those with risk factors. So the take-home messages are follow up early, timely referral to endocrinologist when you see a faltering of growth, avoid excessive weight gain. New genetic causes of short stature are increasingly being found and should be actively looked for. The dose for growth hormone is 33 to 67 mics. Start at a lower dose and build it up if clinically need be. And routine health surveillance is not needed in all adults, but they should be encouraged to adopt a healthy lifestyle.
So Dr. Tawfiq is asking, suppression treatment is recommended before puberty. Counseling will be given by parents. What if child changes his mind and complain that they have not consented for treatment? So this will depend upon the legal status of every country. We definitely see before puberty, why would you suppress is again a debatable issue. So we should really strongly discourage that. And even for DSD now, people are talking about that you should do interventions after they become mature. So this is a big legal issue. There's a big social issue. So we should be very, very careful in whatever we are doing. And that will be an important factor to consider. You can all go and have a look at our website, our courses which are available, and the mobile application. So